Okay, hello again. Hopefully everything's going to be fine now. So let's move back to the repair of the supraspinatus and infraspinatus and talking about the different kinds of constructs we have available. So we should go back to the first question then, which is when should we repair? And clearly there's a lack of consensus concerning this, and the options seem to be largely based on personal experience, as we have already mentioned before, and just like Frank said. And take fatty infiltration, for instance. Long ago, Gutalier said that if you have stage 3 and 4 fatty infiltrations, probably it's no use, there's no point in doing the repair because it will fail anyway. But some years later, Burkhardt stated differently in a subgroup of patients that was quite similar to the previous one. He found there were significant improvements in clinics and also in maintenance of the repair with a similar subgroup of patients. So he stressed the importance of the quality of the construct, of the technique he was using, because in the previous study, many of those sutures were being repaired with single rows. Now, this is the evidence that we have to look for a stable and strong and effective construct. This is one of the several articles you can find comparing single and double row. And this is a recent one that found no statistical significant differences in terms of clinics between one and the other option. But on the other hand, as you can see, there are some other studies that state differently, especially in larger tears, that say that double rows do better than the single rows. But the problem with most of these studies and these reports is the low level of scientific evidence they have. This is a very nice meta-analysis from last year that gathers all the available literature. And they focus on a few level 1 mid and short-term studies that also didn't find so much differences except in the UCLA score in one of the reports. And then you have a lot more long-term studies, but with level 3 that state that the double row seems to be superior in terms of strength and also clinical results when compared to single row. But the conclusion is, even that notion we have for a long time and from this literature that we have available, that cuff integrity does not correlate with shoulder function, may have to be abandoned in a way, because that can turn invalid over time, because some single rows may lead to partial tears, good clinical results in the short term, but the truth is the potential of development to complete tears is high. So probably in the long term, double rows will actually be a better option. So how many rows? Which construct should you decide to do? There are several biomechanical studies that state that the number of sutures, the suture limbs, the kind of stitches you decide to use are stronger predictors of strength than actual construct type, whether it's single, double row, or transosseous constructs. And they conclude that you should try and find a good balance between increased strength of the construct and also an increased risk of type 2 failures, as Frank said before. So what is this type 2 re-tear or type 2 failure? As you can see, and as mentioned before, it's this rupture in the muscular-tendinous junction, which is quite hard to repair. Now, despite evidences that single rows may come along with a higher rate of re-tear, the truth is it's with double rows and suture bridges that you have a higher risk of these type 2 re-tears. So we should try and find modifications for these constructs in order to lower that risk. So what should you do? What modifications are we talking about? They should lower the stress on that medial row of the footprint to avoid strangulation and limit the risk of necrosis on that area, to avoid and minimize the risk of having re-ruptures. How can we do that? You can avoid doing the knots on the sutures of the medial row in order to minimize the tension on that medial row of the suture bridge construct, and also try and find a way to tension the control you give to the sutures when using the lateral row. Now, this is a curious example. This is a patient of mine, so you must be wondering, what is this? Well, this is the pull-out of a couple of anchors that were placed in a medial row in a suture bridge construct. Now, what happened in this case? This is a classical suture bridge. It's not the same case, just as an example. In this case, I decided just to use a lateral, one single lateral knotless anchor in the lateral row. And as you could see, there were knots in the medial row, so there's excessive stiffness there. And then the placement of the lateral row with a punch-in anchor leads to some difficulties in finding the best tension to give to those sutures. So what happened in the previous case was something like this. So the medial row was placed normally, and then when placing the lateral row knotless anchor, the assistant was grabbing and tensioning the sutures. She was not aware of the technique, and I was not aware of what was going on. So the result when punching in the lateral row anchor was the pull out of the medial row anchors. So you should try and find a way of controlling that tension you give to the lateral row. Now, this is also a suture bridge that's placing the sutures from the inside to make sure you grab the two layers of the rupture. Then you do the same. You pass the sutures of the medial row anchors in whatever fashion you like and are used to. And then once you have those 8 suture limbs from the 2 anchors in the medial row, you decide how to fix the lateral row. And in this case, also again, I decided to use just one anchor. This is an anchor that allows you to load the 8 limbs in one single anchor, and then just punch it in. And the beauty of this anchor is that you can estimate the tension you give to those sutures one by one. So you've placed the anchor, and in the middle of the process of punching it in, you can estimate and you can pull on the suture limbs separately and try and give the proper tension to those sutures. So that's a way of avoiding that excessive stiffness you can have with double rows and suture bridges, as stated before. And then once that's done, you've got the tension desired. You just punch it in, cut the sutures, and that's it. Now, the tension band technique, that's one technique I like a lot. We've already focused on the matters of costs, so we should try and find a cost-effective technique. This is not a single row, this is not a double row, but in my belief, this approach is a lot more to the double row than to the single row. Some reports state it's a very good choice. It allows you to have a very high contact pressure at footprint because there's a large area of contact between the tendon and the footprint with good clinical results. And also this report on the right from a couple of years ago clearly shows that it's a very good option for smaller and medium tears. Now, what is it? You surely know that's in a way it's a single row because you just use single row anchors in the lateral row, and then you pass just in one passage, one step. Well, I mean, it's a couple of steps, but you just pass one of the suture limbs through the tissue, through the cuff, in an inverted matrix fashion. This is a small tear, but as you will see, it allows you to have a nice and stable and non-rigid, non-stiff fixation of the tendon against the footprint. So once you've passed one of the suture limbs in an inverted matrix fashion, you just grab the other suture end of the same color, like so, through the same tunnel. In case you don't use a cannula, you just have to make sure you're going through the same tunnel, and then just slide the knot and fix it. And it reduces itself as long as there's not excessive tension on that rupture. And then the same for the other suture limb. So same drill, you just have the trouble of passing one of the suture limbs, tying the knot. It's quick, it's cheap, and in a way, I think it works like kind of a double row. Now I'm going to move to the next video just quickly, just to leave the example that although it's better for smaller and medium tears, the truth is even in larger tears, as long as you can reduce them properly, it works quite well, as you can see. Can you speed it up, please, the video, or I'll just jump to the final slide. So the drill is exactly the same. That's just using that suture passer to load and to pass one of the sutures through the tissue in an inverted matrix fashion. Can you move faster to the end? Just move it to the end, okay? More to the end. Okay, just leave it there. So as you can see, the end result is kind of a complete construct with and the tip of the supraspinatus and infraspinatus against the footprint, and it's completely covered. So there's still one more anchor to go, so I think 3 anchors were used in this case. So which suture type should you choose? Well, definitely it's hard to find the answer. I don't have a magic formula for that. Nobody does. Several factors have to be considered, but today I have the belief that you should do in most of the times kind of a suture bridge, but making sure you don't have excessive stiffness, namely by using tension control anchors and tying no knots in the middle row or using the tension band. Thank you.